This episode was recorded in Q2 2026. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
Some patients can perceive asthma as actually quite a benign condition, that it's not that serious. And I always say to patients that, look, unfortunately, 1 to 2 Irish people continue to die every week from asthma. And for them to accept that persistent symptoms should not be considered an inevitable part of life with asthma, and that most people should be able to live with infrequent symptoms and little disruption to their daily life.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm joined by Dr. Paul Ryan.
Hello John, my name is Paul Ryan. I'm the Therapeutics lead for the Irish College of GPs. I'm a dual trained pharmacist and GP, and I work in Mayfield in Cork City.
This is another one of our two-part discussions, this time focusing on asthma management in primary care, with reference to numerous useful guidelines and resources for GPs and patients alike. As usual, I've included links to these in the show notes along with chapter markers to help you navigate your way through the show. In today's episode, which is part 1, Paul discusses topics including working up patients with suspected asthma in adults and in the 5 to 16-year-old cohort, special considerations for under 5s where objective tests are obviously less feasible, including how to distinguish between and indeed manage episodic viral wheezers versus multi-trigger wheezers in this age group, reviewing and risk-stratifying patients with confirmed asthma, including the risks of salbutamol overuse, and audit and practice improvement opportunities for patients living with asthma under our care. And while we're on the topic of practice improvement and audit, I'm recording this in May 2026, and of course we're in a new PCS cycle. And with that in mind, don't forget you can record listening to these podcasts under the work-based learning section of your PCS record. Part 2 of my discussion with Paul will be released next week, where he will pick things up by discussing recent changes in asthma management in primary care in light of 2024 Joint Guidelines from the British Thoracic Society, NICE and SIGN, an overview of the 5 steps in managing asthma, including the roles of anti-inflammatory relievers, or AIR, and maintenance and reliever therapy, or MART, before wrapping up with reflections on the importance of considering future risk for patients living with asthma, as well as when to refer onward to specialist care. Before I get on with today's episode, if you're enjoying the show, please consider recommending us to a colleague and leaving a review on Apple Podcasts or Spotify to help us reach more people. And if you have any questions, suggestions, or indeed feedback about the show, please drop us a line at podcast@icgp.ie. Okay, let's get on with today's interview with Paul. Paul, thanks again for joining me today. Could we please begin with a scenario? Let's say I have a patient in front of me who I suspect might have asthma. Could you please walk me through the process from my initial clinical suspicion through to diagnosis confirmation?
Really good question, John. So when you're talking about the diagnosis, like any condition, the diagnosis, one of the main aspects to diagnose any condition is the history. So with asthma, you have 4 core symptoms. So there's 2 in and 2 out. 2 inspiratory symptoms, 2 expiratory symptoms. So you've got breathlessness and chest tightness. So those are your 2 inspiratory symptoms. And you've got your cough and your wheeze are your 2 expiratory symptoms. So you need greater than one of these 4 core symptoms. And then, so on top of this history, you need a positive objective test. So an objective test is needed as the clinical diagnosis alone has a high rate of false positives, i.e., for example, you get shortness of breath with other conditions apart from asthma. So the interesting thing about this, John, is that you just need one positive test in combination with a suggestive history to confirm the diagnosis. And this is as per the SIGN, the BTS and the NICE guidance there published in 2024. Prior to this objective test, what you code them as is suspected asthma. So I suppose that would be one of the main things. So if the patient's in front of me and they've greater than one of these 4 core symptoms, well, then I'm going to need an objective test. Just to talk more about the symptoms, they tend to be variable. So what do I mean by variable? They improve and the symptoms can improve and then deteriorate. They can deteriorate during the day, week, season. And this is in comparison with COPD or heart failure or bronchiectasis. They may also have diurnal variation, so where the symptoms are worse at night or early morning, therefore affects the patient's sleep. These symptoms, these 4 core symptoms, are episodic, so you may have minimal symptoms between episodes. They're in response to triggers. So does anything, you'd usually ask the patient in front of you, does anything make these symptoms worse? So we'll just say often they might have a head cold or a sore throat. They may have an urti and upper respiratory tract infection. They may come in contact with allergens or exercise. At the moment, my kids are out cross-country running. So like out, Ireland is, I know in Waterford are very good for their cross-country running as well, John. So when they're out in the field and in a cold evening, you're blowing off all that surfactant. So you're actually, some people may be a trigger for their asthma. If they're around smokers, cold air, pets, birds, or seasonal change as well. These are the triggers. And the final thing is that they may have a personal or family history of atopy. So they may have a history of hay fever or eczema. So I suppose just to indulge me here now for a minute, John, just to kind of go back, the 4 core symptoms, your breathlessness and chest tightness, and then you have wheeze and cough. And the symptoms are variable. They're episodic, they're in response to triggers, and then the patient may have a possible personal or a family history of atopy.
Okay, so as you said, they're the things that we're going to consider in our history, but our history is not enough because of the risk of overdiagnosis on history alone. So now we're going to move on to some of our objective tests. So perhaps you could give me an overview of those.
Yeah, so I suppose it depends on the age group. So for asthma, for adults, you've got number 1, and this is a recent change, it's eosinophil count. Okay, so that's the first one. And then if they have normal eosinophils and you still suspect it, it's moved on to the person has spirometry, and they still suspect it, then it's on to peak flow. So it's a stepwise approach to diagnostic test. So you do the test. If it's positive, asthma confirmed and no further testing required. But if it's negative and is still suspected, proceed to the next test. So adults with a false negative results on eosinophils may be picked up at spirometry or peak expiratory flow. So I suppose just to always think about that, and the pre-test probability is important. So if there's strong clinical features, a negative test does not outrule asthma, especially if they are asymptomatic when they're being tested. So if the person doesn't have symptoms and you're doing eosinophils or spirometry, well, then they may still have asthma. So I suppose that goes back to the very first point about the symptoms being variable, and episodic. So they may not always have. So always have that in mind if you still suspect it.
And I suppose one interesting thing, Paul, from those 3 objective tests is this idea that the eosinophilic picture. Now, if you find that it means you don't necessarily have to do your spirometry or your peak flow diary.
That is exactly it, John. So this is a newly recommended first-line objective test in adults. So as per the BTS sign and NICE. So what the eosinophils do is that they measure type 2 inflammation. Very, very good rule-in test for those with a clinical picture of asthma, so eosinophilic asthma. I spoke already about the pre-test probabilities being important, as some patients without asthma can also have raised eosinophils. So some patients with who are smokers may also have raised eosinophils. That does not obviously mean that they have asthma, so that you're always thinking about the pre-test probability. So if you do strongly suspect asthma, and you do, it's a full blood count I go for. And that's the number 1 before the spirometry. Now, obviously, if it's normal and I'm still suspecting it, then they go for spirometry.
And is any value above the upper limit of normal sufficient to make the diagnosis?
So once it's above the upper once it's above the upper limit of normal, in the presence of the 4 core symptoms that are episodic, variable, his background history of atopy, that's it. Yeah.
Okay. So it removes a potential considerable barrier for some in terms of diagnosis then, especially, if you can nail down the diagnosis without having to fall back on spirometry and peak flow diaries, etc.
That's exactly it, John. Yeah. So it's I think it's very helpful and it's most welcome, to be honest with you.
But as you said, if the eosinophil count is normal, you move on.
Yeah, absolutely, move on. And then if you're still suspecting it, then move on to spirometry and then move on then to peak flow. Okay,
and I think people are quite familiar with spirometry in terms of our listeners. That's very clear to me now about the adults and the importance of the eosinophilic count as a potential quick way of making the diagnosis following your clinical suspicion. How about our younger cohorts where maybe an FBC wouldn't be, possible?
Exactly, and I wouldn't be rushing to an FBC in a 5-year-old. So I suppose in the cohort between 5 and 16 years of age, obviously you're dropping the full blood, the eosinophilic count as a first line test. What you are, interestingly, they actually the guidelines state that you use fractional exhaled nitric oxide. That's not readily available. So you move to spirometry. So it's spirometry reversibility, then followed by peak flow variability. And that's that in that cohort. And I suppose you probably want to know about the meaty part, the kids under 5. Is that right, John?
Absolutely.
Yeah, perfect. So look, you've got, when kids are under 5, obviously you're not going to be doing objective tests. You're not able to do the objective tests on these children. Observation and clinical judgment is used to suspect asthma. And you'll notice I use the word suspect asthma. So you've got your 2 different cohorts here. You've got your episodic viral wheezers, and then you've got your multi-trigger wheezers. So episodic viral wheezers, these are your kids that wheeze only in the presence of a viral upper respiratory tract infection. You treating the wheeze itself, which is not accompanied by respiratory distress, can cause more problems than the illness itself. So I wouldn't be rushing to put them on oral steroids. But whereas that with your multi-trigger wheezers, these are kids that wheeze in the presence of orties, but also other triggers, so that when they're out running around the park, for example, they come in and after exercise that they're wheezing as well. And they may not have the runny nose or the congestion in that. Or if they're around smokers, they can actually start wheezing. The multi-trigger wheezers are more likely to go on to develop an asthma pattern of symptoms than episodic viral wheezers, John. And that's the key here between the multi. So the key question I'd ask is, okay, when the child doesn't have the runny nose, doesn't have the nasal congestion, doesn't have the urty symptoms, are they still wheezing? So we'll reverse back 2 weeks ago when they were playing football out the front, were they wheezing as well? And mum or dad go, no, they weren't actually. It's only in the presence. And that's the key, I suppose, really to ask about. They're phenotypically different, I suppose, is the bottom line.
And then, as you say, Paul, with those episodic viral wheezers, there isn't much evidence around focusing in on the wheeze and trying to manage the wheeze through oral medications.
Yeah, exactly. So I would have seen, I'm pharmacist now since 2005, and you would have seen an awful lot of oral steroids, because back at the scary 20 years ago 20 something years ago, so you dispense a lot of oral steroids to kids under 5, and I've no doubt the guidelines were, prescribers were right to do what the guidelines not instructed them but helped them to decide what to do. But we've seen now in the last few years there's an absolute little or no evidence for that to give oral steroids in this cohort. And you've got your worry about your height restrictions and different things like that. So you're just seeing so much less oral steroids being given to this kids under 5.
And of course, in that cohort as well, it's really natural and understandable, Paul, for parents to have concerns when they see a number of viral illnesses, coming back through the winter season in particular. And I know our listeners have lots of tools and resources to share with parents. And one useful information leaflet for parents and families that you recommend is the HSE's Respiratory Tract Infection Information Leaflet, which is available from the HSE.
Absolutely. So, and John, like the HSE actually have taken this on as well, and they have a respiratory tract infection leaflet, treat your own TYI leaflet for that can be given to parents in the consultation, and it explains that kids themselves can have up to 6 viral infections a year. They may be coughing up to 3 to 4 weeks at a time, so that's a lot of coughing for a year. But there's still, I suppose, just how to manage it and warning signs to look out for that when they need to come back to the doctor as well. But I in this cohort, I wouldn't be rushing to give them oral steroids. And the final thing is that because they're viral infections, they'll only, if they were to get an antibiotic, you'd be concerned about diarrhea or rash. So for them not to get antibiotics.
Okay, so that's really the episodic viral wheezers piece, Paul, where we're less concerned about an underlying diagnosis of asthma. But then you have your second category of patients, which is the multi-trigger wheezers, as you've already mentioned, and they're the ones where you have a greater concern. Is that fair to say?
Yeah, absolutely. Yeah. So like in these patients, these are the kids, under 5 years of age. Who would I be starting an inhaled corticosteroid in? The kids that are more likely to benefit from an 8-week trial or 2-month trial of an inhaled corticosteroid are those that have wheeze or cough in between head colds that responds to bronchodilators. So they're wheezing when they come in from after we'll say that after exercising. So they're wheezing, and if they get Ventolin, then that tends to improve it. These are the patients that will tend to respond to a 2-month trial of an inhaled corticosteroid, especially. Also, the other thing is that if they have a past history of eczema, so they have itchy skin, we say, or they have allergic rhinitis, and then the parent, if one of their parents, especially if their mother actually has a history of eczema or asthma, these are the kids that are more likely to benefit from a trial of an inhaled corticosteroid.
Okay, well, with that in mind then, Paul, I have a 4-year-old, let's say, sitting in front of me, and he has that picture that you've already painted for me as a multi-trigger wheezer, and you're thinking, okay, well, maybe I'm going to give him a couple of months trial of an ICS. How do I go about that?
Yeah, so look, what I would usually do is it's a beclomethasone inhaler between 50 and 100 micrograms twice daily. And you do that for 8 weeks. Explain to mum, and obviously with the spacer, if I have a spacer in my office, obviously I'm interested in asthma. But I'd also say to them that when they go to the pharmacy, to ask the pharmacist to show them as well. But the most important thing for them to do is to stop the treatment after 8 weeks. And that's the key here. Because when you stop it and then you monitor to see was there a disimprovement in the symptoms, and you should only start regular inhaled corticosteroid if the symptoms return within 4 weeks, as long as long-term ICS probably is not necessary. So you stop. And if the symptoms return, well, then you can put them back on. It's, like any medication, you should, the benefit-risk ratio should always be taken into account. Now, if symptoms actually recur after the 4 weeks, so this is week 5, well, then you give a further 8-week trial of the inhaled corticosteroid, but then you stop again and you monitor it. If the symptoms never resolved, then you're thinking, is there an alternative diagnosis like CF going on? So because they should improve with the inhaled corticosteroid. If the child then is still symptomatic at 5 years of age, then you're thinking objective tests, if they're able to do it, spirometry, and a lot of kids, 5-year-olds, won't be able to do it. So then you can maybe try after 6 to 12 months again, let's see, do they have a spirometry. But I suppose at that stage, then it's important that they get the test then.
Okay, Paul. So I've gone through the steps that you outline in terms of my subjective evidence, you might say, in terms of the history, with my objective test, whether that's in an adult or in a younger cohort. And now in my practice, I've got an established population of people living with asthma, as most of us would have in our practices. And now that patient is in for review, and you're seeing them for the first time, Paul, and you want to establish where they sit in terms of a risk stratification for future episodes. How would you go about that?
Yeah, so it's a very good point, John. So and it's the same even in our own patients in our own practice, or else if you're on out of hours and a patient tells you that they have asthma. So a history of an asthmatic attack is the strongest risk factor for future episodes. And the BTS and science specifically state that it's an intrinsic part of the assessment of a patient with asthma. So usually when a patient's like that in front of me, I say, look, in the past year, how many asthma attacks have you had? Okay, so and we say the patient says they've had 3 or 4. Have you had any? So how many times have you, like, they might go, oh, I don't know, how many, then they might remember, how many times have you required oral steroids? So we say a 5-day course of oral steroids. And they say, okay, and then you'll be able to document that. Have they ever had an A&E attendance? So they remember going to A&E, go, okay, Grant. From that A&E attendance, have they ever been admitted to the hospital? Okay, and they might say, yes, I was admitted and I was in for 2 or 3 days. Okay, so when you were admitted to the hospital, were you ever brought to the intensive care unit? So each one of these questions, obviously the risk stratify, past performance is an indicator of future performance, as the man says. So I always say, so what exactly, so we know you have asthma, you have a diagnosis of asthma, we just want to risk stratify it. So that's how I do it it's like having a patient with mental health issues. Were they ever admitted, to a psychiatric hospital? Was it ever involuntary? So something similar. So how many, so I suppose just to say, and then you can talk about the inhalers and how many times you've used the inhalers. And I know you might want to talk to me separately about that, about the Ventolin inhalers as a fair bit there as well.
Well, yeah. It's the other risk factor, isn't it, in terms of salbutamol overuse?
So I suppose, and thank you, John. This is a very good point, and you'll have to indulge me here now for a minute again. I'm sorry now for going off on my high horse. So I suppose, look, the bottom line, it goes back to basics. You should use your Ventolin no more than twice a week. So once on a Monday, we say, and once on a Thursday. When people overuse Ventolin, what happens is it causes the decrease in the clearance of mucus. So it decreases mucociliary clearance. And I can talk about the pharmacology of tachyphylaxis and decreasing cilia action in one. You could talk for half an hour on that, and I won't bore you with that. But the bottom line is that it actually increases mucus production within the airways, which is the whole central pathophysiology associated with asthma. So when you overuse your Ventolin, it causes this, and if the person is dispensed any more than 3 canisters per year, this is associated with a higher risk of severe exacerbations. So I suppose just to always make sure that if the patient's on Ventolin, if they're taking the Ventolin, that they're also taking an inhaled corticosteroid. So I suppose that would be the main thing there. So I suppose I always say to patients, some patients can perceive asthma as actually quite a benign condition, that it's not that serious. And I always say to patients that, look, unfortunately, 1 to 2 Irish people continue to die every week from asthma. So look, and for them to accept that persistent symptoms should not be considered an inevitable part of life with asthma, and that most people should be able to live with infrequent symptoms and little disruption to their daily life. And that's hugely important. I stress that to patients, that they should be, infrequent symptoms and little disruption to their daily life. Asthma should not be causing any more than that.
Yeah, thanks a million for that really important message, Paul. I suppose it is a risk, isn't it, that patients start to feel that their ongoing respiratory symptoms are intractable, whereas, as we know, the reality is that for most, things can be optimised, and it's important that they speak up and let us know so that we can help them to get to a better baseline. And that number of 3 inhalers per year, it's based on quite simple maths, actually, isn't it?
Yeah, no, it is. And I suppose just to go back, there was a study done, published in the European Respiratory Journal in 21, and a previous study back in 2012 that showed that, more than 3 canisters a year associate high risk of severe exacerbations. But I suppose just to go back to basics, so people who have controlled asthma do not need their asthma inhaler any more than twice a week. So we'll just say, for argument's sake, they have 2 puffs on a Monday and they have 2 puffs on a Thursday. So that's 4 puffs a week. 52 weeks in the year, 4 by 52 is 208 puffs a year. How many puffs in a Ventolin inhaler or a salbutamol inhaler? Is 200 puffs. So really, you should only need one inhaler, but two inhalers is the maximum. So I suppose that's what I hammer home to patients about the importance, because when you have 3 canisters a year or more, just think about you're decreasing the mucociliary clearance, you're causing more mucus plugging, and it leads to more severe exacerbations.
And I guess, given that most of us are using electronic records these days, Paul, it could be a potentially quite a nice audit to have a look at how much of things like Ventolin your patients are getting across the average, and to see whether a practice improvement could flow from that.
Yeah, absolutely. Yeah. So I know that Shane McHugh, the respiratory lead for the Irish College of GPs, he has created an audit tool to help you actually look at the amount of Ventolins that in your practice that you're prescribing. So I know that's there's a plug there for that audit, but feedback has been very good on that.
Many thanks again to Dr. Paul Ryan for speaking to me today. And don't forget to check the show notes for chapter markers and links to resources. And as I mentioned at the start, part 2 of this 2-part conversation with Paul will land in the show feed next week. Do feel free to get in touch by contacting us at podcast@icgp.ie. And that's it for today's show. Thanks again for listening, and until next time, take care.